Hello, friends. So we are back with another session of conceptual surgery topics and to be discussed. And today we are taking a rare but very intriguing tumor of breast. Normally in breast, we talk about carcinoma of breast or benign tumors. But today we'll be talking about something which is somewhere in between. It is not benign, maybe it can be benign or it can be malignant also. It's called Phyllodes tumor of the breast. So, as you can see in the image, historically, many people have reported huge masses in breast, which was disfiguring and very rapidly growing and very soon. But they were not malignancies, but because they were not infiltrating or leading to metastasis or recurrence. So that's why they were handled differently, and that's why they were classified as a very different tumor. So today we'll try to understand uh, the pathology of Phyllodes tumor. We'll try to recognize the clinical features and how they present and how we diagnose them. We also will try to see what is the management strategy which we use, and we also will discuss slightly about what's the prognosis and how they should be followed up. So So in 1838, way back in 1838, a surgeon named Johannes Muller, he described it this as a Cystosarcoma Phyllodes, which name still is there, but many experts do not like this name. So he called this Cystosarcoma because he described it as a tumor which is growing into leaf-like projections, and leaf means phylodal. So from where the name came, Phyllodes, and also it was leading to some cystic generations uh, in the case which he described. But now that we know that uh, there it's not a sarcoma, so it cannot be called a cystosarcoma. It does not. It's very rarely leads to cystic changes or cystic degeneration. So in areas we'll not find much cystic areas. So that's why the name now standard is Phyllodes tumor as given by WHO. So this is what we need to remember. Then it's a rare tumor. We all know it's less than 1%. Many people have said the incidence is between 0.3 to 1%. And if we see only fibroepithelial tumors, it comprises 2.5% of them. Now, when it is 2.5, the rest 97.5% is fibroadenomas, so which are very common. So a very rare variety of fibroepithelial tumor is Phyllodes tumor. Age, it can be any age, and the peak is at 40 to 50 years, and but it has been reported from as less as 10 years to as high as 80 years. So there is no particular thing, but yes, it is mostly seen in uh, 40s to 50s age group women. So what it is actually, this tumor gets originated in periductal stromal cells. So in that area, both the epithelial cell as well as the stromal component, they both starts growing, and that leads to this peculiar uh, Phyllodes tumor, which has both stromal elements as well as epithelial elements, and that is why this cystosarcoma was initially used, but now it's called Phyllodes, and that's why it's called fibroepithelial tumors also. Though it mimics fibroadenoma in way I'm saying, because it has fibroadenoma also has fibrous elements as well as adenomas means epithelial elements, but the stromal elements, like different stromal elements, are not seen in fibroadenoma. So they clinically they mimic each other, but histopathologically they're very different, which we'll see. And genetically, if we see, currently most work or most research is being done around MED12 mutation, which is something common between fibroadenomas as well as Phyllodes tumor. In both, we get MED12 mutations, but other things which generally were not seen in fibroadenomas but were seen in Phyllodes tumor were Leaf-Remini syndrome and TP53 and BRCA1 gene mutations. So Clinical presentation wise, typically women which are more than 30, typically 40 to 50 age group, they will present with a rapidly increasing size, a painless tumor, which is huge in size, and it grows very fast. And when it grows very fast, it stretches the skin on it. Even though it is of large size, it does not lead to fixations. It does not lead to ulceration of the skin very easily. Very late, when it becomes huge in size, because of the pressure on the skin, it ulcerates. And that's the only thing, but not infiltrating it. So that's why it's not a malignancy like that. If a size is more than 10 centimeter, we generally refer to them as giant fibroadenoma, giant tumors or giant phyllodes when it's more than 10 centimeter. The only difference is these giant phyllodes, they will have some area of necrosis, some area of degeneration, which is again because of pressure, and also can have skin ulcerations. So it will, till late, it remains mobile on the chest wall. It rarely infiltrates. It can lead to necrosis. Occasionally, it can be bilateral. Mostly, it is unilateral. Occasionally, it can be bilateral also. Now, axillary lymph nodes are seen. Typically, they should not be seen because this is a sarcoma. It doesn't spread via lymphatics. But in some cases, maybe because of degeneration and that leading to inflammation, lymph nodes are seen in as much as 30% of cases. But uh, they're rarely showing the changes of fibroadenomas or phyllodes or any malignancy. So they're not involved in that way. So, uh, so overall, you'll find a person or a lady complaining of huge mass, rapidly increasing, uh, and no axillary lymph nodes. That's also a clincher towards diagnosis of phyllodes tumor. A huge mass with no lymph nodes. Again, if you compare it with malignancy, uh, carcinoma breast, uh, it's very uncommon that a mass which is in the range of, let's say, 6 centimeter, 10 centimeter, 15 centimeter will not have lymph nodes. But in these cases, then we see that. So this is one picture which we recently operated. You can see how huge the mass is and how what it leads. This patient also does not have any lymph nodes clinically palpable. When we operated, then we did find some small lymph nodes. And when we sent them for biopsy, it was it just showed reactive changes. So this is a Cystosarcoma Phyllodes. And if you, this one case is also has ulcerated skin. So if you see the surface uh, of the tumor, it is showing very fleshy kind of appearance, which is very different from what malignancy shows, and which is how typically this tumor grows. And that's why I wanted to show you this picture. So when you do examination, you'll find a mobile, firm, well circumferenced mass. It is of size, of large size generally. Uh, Again, huge sizes are also reported, as you saw in the first image. As much as 5 to 7 kilogram masses have also been removed, which were phyllodes tumor. If you do ultrasound, you'll find as the typical feature is that it will be well circumscribed, it will be solid, it will be lobulated mass, which will be hypoechoic. So that is what the feature is. And on mammography, again, you'll find a well circumscribed polylobulated lesion, which has smooth borders. And so typically it is same as a fibroadenoma on mammogram. So on mammogram, on ultrasound, even on MRI, it's very difficult to differentiate whether it's a fibroadenoma, it's a benign phyllodes, it's a malignant phyllodes. It's very difficult. So, but it just tells you that it's a well-defined polylobulated smooth margin mass. That's it. And then we go to next step. So in MRI also, in MRI typically we don't need it much, but whenever there's a huge mass, I think it's better to do some imaging which will tell you the extent of the mass, that how big is the mass and where all it is going, and whether it is going into the muscles or not. So for the extent of large tumor, we can do MRI of the breast. So it is difficult to differentiate, on the basis of imaging, whether it's benign or malignant. So generally we resort to biopsy, but even FNAC and coordinator biopsy preoperatively sometimes can be misleading. So yes, if it can give us